Hello everyone, thank you for joining us today. My name is Jenny and I'm a part of education team at Medit. Nice to meet you everyone. And today we have Dr. Michel for the first time joining with us. Hello doctor.
Hi Jenny, how are you?
I'm good, thank you for asking. What about you?
I'm fine. Hello everyone and welcome to this interesting webinar with Medit. Hope you will going to enjoy our information today.
Yeah, so today Dr. Michel prepared a lecture about full arch. It's going to include so many clinical tips, right?
Yes, actually this webinar is dedicated to dentists who are working with single implants and looking forward to start working bigger full arch cases. So I'm going to give you some hints to work your full arch case over implants.
It's my favorite one, so I'm very, very excited. So before we
Okay.
get started, let me briefly introduce about Dr. Michel and move on to the lecture.
Okay.
Okay, so this is a profile page of Dr. Michel Magdi Monir. So is it right to pronounce your name?
Yes, I'm Dr. Michel.
Michel, yeah. So Dr. Michel Magdi Monir holds a Bachelor of Dental Surgery from Cairo University and did further study of fixed prosthetics resistancy in the same university. And we can find very interesting experience here. He taught the prosthodontics in the Cairo University where he earned a degree. And he started CAD/CAM since 2018, which means now it's 7 years. And he has specialty in implantology. And the last, he's a private practice owner in several dental clinic since 2013. So it's over 10 years. Wow. So it seems like you had an interest in becoming a professor because you are in the same university as an assistant. Is it?
Yes, but nowadays I'm really interested in clinical implantology and digital workflow, especially of implants. Actually, clinical work is giving me much time to learn on different cases. Every day you see a new case with a new story.
Wow, that's a good mind. So is there anything you'd like to add or correct?
I think it's clear, yes? Yeah.
Okay, then let's get started. Shall we begin, doctor?
Yeah, sure. Yes.
Okay.
So let's start our webinar. Big welcome to everyone joining us today. I'm Dr. Michel, and today's topic is a quick guide before your first case of full arch implants. But before we start, let me introduce myself first. I'm Dr. Michel Munir. I'm a prosthodontist with special interest in digital implant dentistry. I have been working digital since many years ago, and I remember working with many generations of scanners, starting from BlueCam, OmniCam, Medit i500, i700, and I have just finished trying the new i900. I believe digital dentistry is not only about scanning. Digital dentistry is a full solution to help you give your patient the best treatment. So this webinar is for every dentist who has started working with dental implants and now wants to move to the next step and is interested in doing full arch cases. But before we start, let me show you this case first. Now you can see we have a case of full arch over implants having severe aesthetic failure. There is no doubt that the implant's success is not only about osseointegration. It's not the issue here because we can have here osseointegrated implants, but the restoration and the patient experience, we cannot say there is success here. And if you want to avoid this, and this is how I do my job, you can feel the difference now. You can see the arch, the teeth with the shaped gingival papillae. You can see the anatomical imitation of the original dentition. So let me take you now in a tour to see how we can do this work. This is also the same case, the final results before treating the lower arch. So the fact is, we don't plan full arch implants, we plan a patient's third dentition. And that's very important because sometimes people think, or dentists, that you plan where you are going to put your implants in the patient's bone, but you don't give much care or planning to the final restoration. And that's a big deal. You have to think of the patient's third dentition, the last dentition. He had his primary when he was a child, he has his secondary dentition, an adult, and now you are giving him the third and the last one. So you have to think of the dentition, not of the implants you are going to place. This is what we think about, the final teeth, the final dentition that we are going to place. So now our topic is the quick guide before your first case. What we are going to talk about today, we have 4 little topics. The first one is 4 steps to a patient's third dentition. The second is aesthetic and functional considerations during full arch planning. And the third one is all on X, how many implants needed. And the last one is full arch scanning hints. So let's start. First of all, you have to plan your case. And to plan your case, I'm going to give you a very rapid scheme. 4 steps to plan your patient's third dentition over the implants. The 4 steps are listen, examine, acquire, then plan. Okay? Listen, examine, acquire, then plan. Let's take a look on each point separately. You have to listen to your patient carefully, and that's of crucial importance. You have to listen to his medical history. Is he ready to get a full arch treatment as a medical condition or not? To his dental history, what caused him to lose his teeth or to get this stage of bad oral hygiene? You have to listen to his lifestyle. Is he working? Is he retired? What's his chief complaint? Is it pain, eating, phonetics, aesthetics, all of the above? What's his prime chief complaint? And what's his patient's expectations? And actually, this is very important because I remember a couple of months ago, I had a patient seeking a third dentition over implants, a full arch treatment. And actually, after listening to her and talking with her, I realized that her expectations was like having a Hollywood smile, a veneers over teeth. That was she was expecting. And she had severe problems in her jaw bones and in her soft tissue. So you had to listen to the patient and think about what you are going to give him and is his or her expectations achievable or not. And you have to talk a lot about this. So what you are seeing in front of you now, probably many of you know what this is. This is what we call Maslow's hierarchy of needs. Okay, this pyramid consists the needs of human being, like a pyramid, starting from the bottom to the top. As you move upwards, the needs are of more luxury, and the basic needs are at the base of the pyramid. So as you can see, the base of the pyramid is the physiological needs. Anyone needs to feel anyone needs to feel no pain, not hungry, not thirsty, and can breathe. And sometimes you get a patient who is in severe pain, who can't eat, and this is probably your patient is at the base of the pyramid. He has physiological needs. Then moving a step upward, your patient may be able to eat, to to drink, he doesn't have pain, but he doesn't feel safety. He feels that his teeth or her teeth may fall or may get broken during eating or may fall during talking. So your patient has safety issues about his teeth. And then the next step in the pyramid is social needs. Your patient may have teeth and he is not afraid of breaking them or he doesn't have pain, but his appearance is not acceptable. He cannot show his teeth to his family, to his friends, to his colleagues in the work because they are not of proper shape or aesthetics. So he has social needs. And then going upward, you have the self-esteem that the patient is satisfied with his teeth and he is proud of his teeth and he thinks that he can not only feel satisfied, but he is felt admired and respectful because his smile is fine. And the last one is self-actualization, which means that the patient wants the best treatment and the best aesthetics and the best thing available for his or her teeth at all. And the most important here is that you have to realize in which part your patient is coming to your office, in which part he is of the pyramid. What are the patient's needs? Is he at the base of the physiological needs or at the safety or the social? You have to put your patient within this pyramid to see what are the real needs that he wants to achieve. So moving on to the next point is examining your patient. You have to give special interest examining the remaining teeth, the residual infection or lesion if there is any, the gingival biotype, the arch form, the inter-arch space available for the future restorations, the occlusion, the oral hygiene of course, and your patient's phonetics. Don't forget to check them. Take a look on every aspect of the remaining teeth, if any, of the gums, of the oral hygiene. As you can see, there should be a lot of problems in the oral hygiene. And you have to take notes of all of these to see how you are going to manage each case alone. Then the third step is acquire. Now it's time to bring your Medit scanner and start acquiring data. You are going to start acquiring intraoral and extraoral face scans, intraoral and extraoral photos, and CBCT cone beam X-rays. This is the i700 I'm using, and I want to tell you about the i900. That is, it's having a very interesting large tip. As you can see, there is two tips available for the i900, the medium one and the large one. The large tip on the right side helps you a lot in scanning full arches because it has a wider mirror and works very fine with full arch cases. So first of all, take a scan of the initial condition of the patient, whatever it is, whatever the condition of the teeth, take a scan of it, okay? And after you finish your scan, a very interesting tool to take is the ortho capture. The ortho capture will take you screenshots of various sides of the occlusion and the arches, upper and lower, frontal and side views of the occlusion. These photos will help you a lot during planning. Whatever also the condition of your case, take a scan. Always take a preoperative scan to see every aspect like you see in the photos. And it's also of prime importance to take a face scan for these cases because you are going to shape the anterior part of the arch and you want to avoid any canting or midline shift, and the face scan will help you a lot to do this task. Then bring your camera and start taking photos, intraoral and extraoral photos of your patient's teeth and his smile. You should think a lot of taking also videos for the patient while talking to see the amount of teeth showing and if there is any gum showing when he talks. After finishing taking your scans and your photos intraoral and extraoral, take also a cone beam, a 3D X-ray image. This is the main part to plan your future implants, because we are going to use all the data together with the X-ray to plan the implants and the final prosthesis. Now, the fourth step, planning. You can use Medit design, different apps or softwares for digital smile designing, and CAD softwares and implant planning softwares. This is how you integrate the patient's cone beam CT with the scan using the Medit design app. This will help you a lot see what's behind what you see in the patient's oral cavity. You see his jaw bones. And also you can combine the face scan with your data to see any canting that is existing. Is the canting existing from the previous teeth, or the canting is from the jawbone itself? This is how we plan implants over the X-ray. And you also have to plan the prosthesis, because as we are talking, we are planning a third dentition, not only implants. So it is of crucial importance to plan the future teeth before starting, because it will help you a lot choosing the best suitable places for putting your implants in the jaw bones. Why? Because we want the screw channels coming out of the restoration to be in favorable place. And as we say, a favorable place for the screw channels, we mean that the screw channels are coming from the cingulum of the incisors or the anterior teeth, and from the middle of the occlusal surface of the posteriors. So to achieve final results at these with screw channels hidden on the palatal surface of the upper and on the lingual cingulum of the lower and on the occlusal surface, not coming from the buccal sides, you have to do a proper planning of the future teeth together with the implants. So you are guided to put the implants at the desired place under the future teeth. So this is an example of a planning for this case. On the right side, you have the occlusion before, and on the left side, we are planning to put full arch implants for the upper and extracting the remaining teeth. And this is the final or the temporary design, maybe can be adjusted finally. This is the temporary design for the teeth that we are going to place immediately after extraction and putting the implants. And this is the teeth in action in place after putting the implants. This is how the occlusion looks, and this is how the patient smile looks. This is the final restoration after healing, and this is the occlusion, the final one. Here it is, the case before and after. You can see big difference in the patient's occlusion and also in the patient's aesthetics, and of course in her self confidence. So also during planning, you have to think if you are going to use a surgical guide or you are going to work with a free hand. This is a large topic that we don't have enough time to cover now, but this is one of the parts you have to think about during planning, because some cases need surgical guides to get proper results. Now we have finished our first part, the 4 steps to a patient's third dentition: listening, examining, acquiring, and planning. Let's move to the next part, which is the aesthetics and the functional considerations during full arch planning. So you have to examine the remaining jaw bones of the patient and determine what is the amount of bone resorption? So on the left side, your patient has no bone resorption. It means that he only lost his teeth. So this means that the final restoration can be only the shape of teeth, white only, without any pink. Then in the middle there is amount of bone resorption. It may be mild, it may be moderate, and this is an indication that your future restoration should be composed of a part of white and a part of pink under the white to replace the missing gums and bones. And on the right side, we have the advanced composite defect, which means that the patient has lost most of his bone structure around the past teeth, which means he has a big part of the jaw bones, alveolar bones lost. You have to think of replacing the teeth and a big part of the missing hard bone and gingival missing. And the same for the mandible. You have to evaluate the patient's condition. He lost teeth only or teeth and jaw bones and soft tissue also. And according to Mish, there is a Mish classification that classifies the amount of bone loss and the teeth loss into 3 categories. We call them FP1, FP2, FP3. FP goes for fixed prosthesis. 1 means that your patient only will receive white teeth. This is an FP1 case. And an FP2 case, there is some bone loss around the teeth, so the patient may receive some pink around white teeth. So it's a mixture of pink and white, but not a major big pink part. And the last one is an FP3. There is a major part lost from the bone and the gingival tissues. So you are going to replace them with the teeth as a mixture of white and pink. Well, in general, it is preferable that your final restoration, rather be an FP1 or an FP3. Because when you have an FP1 restoration, only white, your patient's gum is his original gums, so it looks totally natural. And an FP3, you are replacing the patient's gums with a huge part of the gums, so it looks homogeneous and natural. But when you are doing an FP2, you have a mixture of pink between the patient's original gums and the artificial pink you are placing. And this gives less aesthetics. So always try to fall into the category of FP1 or FP3. So as you can see now, FP goes for fixed prosthesis. You can also use removable prosthesis whenever you have big loss in the jaw bones, which we call RP4 and RP5, which means that the restoration is removable. The RP4 is mainly an overdenture completely supported by implants, and the RP5 is an overdenture supported by both soft tissue and implants. So before starting your case, you have to realize in which category your final teeth will fall within the FP1, FP2, FP3, RP4 or RP5. So this is the example of the case I have just shown to you. It's an FP1. The patient receives only white teeth and his gums are totally natural. And this gives excellent aesthetics. But you can't do this for all cases because many of patients have lost a big amount of the bones and the soft tissue around teeth. So you can't replace all of this part only with white. And this is an example of an FP3 restoration. You can see now the big pink part around teeth, around crowns. and it is totally homogeneous, so it looks natural with the patient, and there is no aesthetics decrease. So you are trying always to work between FP1 or FP3. So also you determine the type of prosthesis you are going to use according to the available inter-arch distance. Let me explain this to you. If you have inter-arch distance between 10 to 12 millimeter, now you have to think of a fixed option. You don't have the option to do removable overdenture over the implants. You should do something fixed, and probably it will be an FP1 because the limited inter-arch space will be only for white teeth. If you have larger space, 12 to 15, you have the fixed option of FP1 or FP3. And if you have larger 15 to 18 millimeters, you can also think of fixed FP3, or you can think of removable overdenture. If you have inter-arch space larger than 18 millimeters, please do not do a fixed option. You have to think of an overdenture over the implants. So sometimes we need to do some alveolar bone reduction before putting the implants, which we call also plateauing or all-on-shelf concept. This reduction helps you prevent slippage during drilling for the implants. It also increases the available bone thickness for putting the implants and increases the prosthetic space between the two arches, so you can work FP3 without any compromise. And also it helps hiding the prosthetic tissue interface in case of high smile line. And finally, it has a prosthesis that is more hygienic. This is how the bone plateauing looks like after you remove the knife edge part of the ridge and you are working on a wide part of the jaw bones. This is where you are going to put your implants. Now this is an example of a case done without plateauing. You can see the margins of the restoration going up and down. And this is not very hygienic. And regarding aesthetics, it may not be showing if the patient has a low smile line. The low smile line will be hiding the transition zone. But if the patient has a high smile line, like the case we have just seen, the transition zone is showing, and so the aesthetics are compromised. The third part today is all on X, how many implants needed. So the number of implants, the X number, depends on many factors. It depends on the available bone in anterior and posterior segments, the anatomical limitations, which means the nerve in the mandible, the inferior alveolar nerve, and sometimes the nasal cavity and the maxillary sinus in the maxilla, the arch form and size, the bone density, is it of high or low density, the forces of mastication, which depends on the patient's age, the patient's sometimes the gender and the face type, and also the opposing dentition and how heavy is the occlusion. And the type of prosthesis also you are going to use. Are you going to use a heavy titanium framework and zirconia crowns, or just an acrylic overdenture? So this is very important slide of evaluating the maxillary zones. You have to divide the maxilla into three parts: Latin 1, Latin 2, and Latin 3. Latin 1 means the anterior part from mid-canine to mid-canine jaw bones. Latin 2 means from mid-canine to the distal of the second premolar. And Latin 3 means the posterior molar part. You are going to evaluate the maxilla in the three Latin 1, 2, 3 and see the existing bone. If you have bone in parts 1, 2, and 3, you can put easily 6 implants at the position of the upper lateral incisor, at the position of the upper first premolar and first molar. So 3 implants on each side, 6 implants in the maxilla is a very acceptable plan. Now, if you have bone enough in only zones Latin 1 and Latin 2, but in part 3 you don't have enough bone, you can shift to the all-on-4 technique, which means you are going to put 2 implants at the position of the lateral incisors and 2 implants at the position of the second premolar, which are going to be tilted to increase the space. And we are going to see all the details about the all-on-4 right now. The last type, where you don't have enough bone in Latin zones 2 and 3, and now you have to shift to using a long implant engaging in the pterygoid or the zygomatic bones. So what is the concept of the all-on-4, the treatment concept by Paulo Malo? The concept is to put 4 implants but tilted. Tilting the implants towards distal, to put longer implants and to increase the anterior-posterior spread between implants, and also to avoid the anatomical structures that you cannot avoid. So you put your implants, the distal ones tilted and the anterior ones, the middle ones, straight. And thus you are avoiding the maxillary sinus in the maxilla and the inferior alveolar nerve in the mandible. So this is an acceptable line of treatment when you have bone only in the Latin zones 1 and 2. So how you are going to tilt your implant? There is a wing, a special wing called Malo's wing, a special metal device with showing the angles used to put the tilted implant in the posterior, so you can avoid the inferior alveolar nerve in the mandible. And also you have to think of the anteroposterior spread. The anteroposterior spread, or the AP spread, is the distance between the most anterior and the most posterior implants. And as you increase the AP spread, you can increase the distal cantilever part of your prosthesis. So during planning an all-on-4 case, always try to increase the AP spread. The AP spread is also affected by the arch form, because different arch forms give you different AP spreads. So good preoperative scan and good preoperative photos and planning will help you choose the best positions for your implants to get the maximum AP spread available, and this will give you the largest posterior spread also. And now let's talk about some full arch scanning hints with your Medit scanner. As you all know, scanning full arch implant cases immediately after extraction and putting the implants may be difficult because of the existing blood, because of the change in the soft tissue, because of loss of teeth. So the scanner may find no starting point to track from as from the preoperative scan. So let me give you now some hints for scanning such cases. First of all, to scan a maxilla is a little easier than scanning the mandible, because the maxilla has the palatal rouge area, which will not change before or after putting the implants or extracting the teeth. So it is a good reference point for the scanner. The issue now is having a good reference point for the mandibular scan. And I have some tricks for you now. The first one is you can leave behind some teeth without extraction after putting your implants. You can choose one or more teeth that you are not going to extract until you place your implants and you take your scan. So these teeth will help as a guide for the scanner to take the final scan with the implants, and then you are going to extract these teeth and put your restoration. So you can leave only one tooth or two teeth to help the scanner for better tracking. And you can also overcome the problem of scanning of long scan bodies distant from each other by connecting the scan bodies by elastics. You can use variable types of elastics available in the market to connect your scan bodies, and this will help a lot of scanning the long metallic scan bodies and connect them with your scanner. And I always prefer to use yellow elastics, which is easily identified by my Medit scanner. This is how the scan looks with the connection, but take care that your elastics are in the middle part of the scan body, so you may not hide the connection between the scan body and the multi-unit abutment. Also, another hint is scanning the existing patient's denture before putting your implants and using it as a guide for your future occlusion of the final prosthesis. I prefer doing relining of the denture using a light body rubber base with a blue color, and I am using this denture and the occlusion of the previous denture to help me in fabricating the final prosthesis of the patient with an vertical dimension of occlusion similar to the dentures one. And this is how I use my denture or the patient's denture with relining material to help it getting seated on the edentulous scan of the patient. So hope you had some great information from this webinar. Thank you all for watching, and now please tell me if you have any questions.
Okay, thank you for sharing all your tips with us, Dr. Michel. That was so useful and interesting.
Yes, thank you. Hope it gave enough info for this topic.
Yeah, I hope everyone also did. So how was your first webinar?
Well, I enjoyed a lot.
Me too. Okay, so let's move on to Q&A sessions.
Okay.
So today we have 3 questions in total. I will start with the first one. Question number 1. In full arch cases, what is better for oral hygiene and maintenance, one-piece prosthesis or segmented bridges?
Well, for oral hygiene and maintenance, it depends according to the height of the restoration. So in FP3 cases, where you have a long restoration with white and pink, it is better to make it as a one arch, because if it's segmented, it will be very difficult to clean and floss between. However, in FP1 cases, where there is only white teeth, you can segment into 3 bridges, anterior 1 and 2 posteriors. Except in immediate loading cases, it is always preferable to make it splinted. So in immediate loading, even if FP1, it is always preferable to do the restoration as a one piece to splint the implants together.
But it's all done by case, right?
Yes, it depends on the immediate loading, yes or no, and the restoration type, is it an FP1 or an FP3?
Do you sometimes do immediate loading?
In immediate loading, your patient cannot wait without teeth, so you have to put him immediate teeth after putting your implants. And by doing the one arch prosthesis, the connected one, you get a benefit of splinting implants together, so you decrease the micro movements, which will give you better osseointegration.
Okay, so thank you for answering about it. Let's move on to the next question. Okay, question number 2. It is always challenging to adjust the common path of insertion, and it is even more challenging as the number of implants increases. So do you have any specific tips to promote parallelism?
Well, in full arch cases, we use the multi-unit abutments. The multi-unit abutments are designed with different angles to help parallelism between implants. So even if your implants are not parallel in the jaw bones, which happens a lot due to tilted bone in the maxilla or in the mandible, you can adjust the parallelism by using a multi-unit abutment over the implant with angles ranging from 0 up to 45 degrees. So each implant company has multi-unit abutments with different angles, maybe 15 degrees, 30 or 45 degrees. So I always advise you to put the multi-unit abutments on the same day of the surgery. So you can adjust the angulations of all the implants together and correcting the parallelism using the multi-unit abutments. This is the best way to get good path of insertion between the final implants, screw channels from the restoration.
Okay. Okay, we are left with the last question. Question number 3. There are some cases still having many teeth, but hopeless due to gum recession and bone loss. Is there any tip to consult them to extract the remaining teeth and move on to arch implants?
Well, let me tell you, I'll get back to a slide in the webinar where I talked about the patient desire and the patient expectations and what is the main reason that made him come to the office seeking implants. I always advise my patients that if there is very few remaining teeth, maybe 2 to 4 teeth, it is always better to remove them during or after the surgery and putting a full arch implants. But in other cases, you still have multiple sound teeth with good periodontal support. So you can mix between teeth with crowns and implants as a final arch. So I think there is no general rule for all cases. It is very tailor-made to each patient. But as a general condition, always make the priority to the bone, that the remaining teeth, the existing teeth, if they are of poor health and poor periodontal condition, they may lead to bone loss after a while. So always tell your patient that his jaw bones at this stage are more important than the remaining 2 or 3 teeth. So always give the advantage to the bones and the health of the alveolar bone. If existing teeth will make further bone loss, then you have to remove.
But it's costing a lot, right? When it goes to fixed full arch case. So it's really a bit challenging to consult the patient, right?
Yes, of course. As we always tell our patients, dentistry is not expensive, but neglecting teeth is. So making a full arch prosthesis over implants actually is a result of neglecting teeth for years. So that's what I tell my patients. If you had enough care to your teeth during the last decades, I think we would have better situation. But in some cases of neglecting teeth for decades, it will end up by bad oral hygiene, losing periodontal tissue and teeth, and then we have to go to the right decision of full arch.
Oh, yeah. Okay, thank you for sharing your tips.
You're welcome.
Okay, that was the last one. So yeah, that's all about it for today.
Okay, thank you so much, Jenny, for this webinar. I really enjoyed being with you and with Medit. Hope to see you all soon.
Yeah, it was so great to invite a new KOL to our webinar. So we'll come back with diverse and useful topic next time. So please let me know any topic or any feedback. Okay, thank you for being here, Dr. Michel.
Okay, thank you, Jenny.
See you next time. Bye.
Bye.